So as mentioned before, this conference is being put on by two societies. The first half being InciSioN UK, and the second being NANSIG. So for a little introduction into InciSioN UK, InciSioN UK is a student and junior doctor-led group that is working to promote access to safe surgery. This is for everybody across the world, but they're aiming to spread this awareness primarily in the UK. So for the committee, we have 15 medical students and some junior doctors all across the UK. And we work together nationally with international partners to promote global surgery in three key areas of work. The first being research, the second being education, and the third being advocacy. InciSioN is actually a global organization, but we represent the UK branch of this global nonprofit organization and have multiple university representatives all across the UK. InciSioN UK is pretty active throughout the year, and we aim to promote global surgery nationally by undertaking multiple projects and social media efforts. These include monthly hosting of surgical journal clubs, educational workshops and webinars and conferences, spreading awareness across global topics. Other examples include the production of themed posters and blogs every month, bringing awareness to different nations across the world without the same access to surgical advances. And if you would like more information about InciSioN and what they do, feel free to get in touch, and there's some links here on the screen displayed now. For the second organization involved in the running of the conference, we are NANSIG. So if you don't know what NANSIG stands for, NANSIG is actually the Neurology and Neurosurgery Interest Group. And this was actually established about 12 years ago in 2010, and it's both run by medical students and junior doctors alike. NANSIG has over 1,700 members in over 35 countries across the world. And throughout the year, we provide and produce educational materials, mentoring opportunities, research papers, webinars, and conferences throughout the year. All of this culminates into our annual flagship event, the annual Careers Day, which attracts over 200 delegates and runs in association with the SBNS, or Society of British Neurological Surgeons. Essentially, NANSIG functions to enable members to gain insight and experience into neurology and neurosurgery. And this is achieved through improving knowledge via educational resources, commitment in teaching and applying said knowledge, commitment in leadership and developing said leadership, improvement of psychomotor skills, collaborations in research, and opportunities for prizes and achievements as well, some of which will be discussed later on in this conference. And if you want to know more information about NANSIG, similarly to before, please feel free to get in touch, and our social media links are provided here below as well. So like mentioned before, we do have 6 speakers here today. I know we're running maybe a little bit ahead of schedule, but that hopefully will give us some time to introduce more things in the Q&A session. I've noticed we do have our first 2 speakers here today. And for our first speaker, I have the esteemed pleasure of introducing Professor Jeffrey V. Rosenfeld, AC and OBE. So Professor Rosenfeld is an internationally recognized Australian neurosurgeon and is an emeritus professor of surgery at Monash University in Melbourne. He's also a senior neurosurgeon at Alfred Hospital in Melbourne and adjunct professor in the Department of Surgery. His research interests focus on improving the outcome of traumatic brain injuries and restoring sight to blind individuals with a wireless electrode interface with the brain. He's a former Surgeon General and a retired Major General for the Australian Defence Force, and has served as a military surgeon in Rwanda, East Timor, Solomon Islands, Bougainville, and Iraq. He has worked over many years as a neurosurgeon in Papua New Guinea and some other developing countries as well. His books consist of Neurosurgery in the Tropics, a practical approach to common problems for the isolated practitioner, and Head and Neck Injury. These are some great books, and hopefully these will be of interest to some of the conference participants here today. Thank you so much for joining us, Professor, and we look forward to hearing more from you speak today.
Thank you, Joshua, and thank you to your organizing committee for inviting me. I'll just share my screen now with you. Just let me. Let's see. You see my screen now?
Yes, you can see it, sir.
You've got my first slide there?
Yes, you can see the first slide.
Getting involved in global surgery and neurosurgery. Look, I thought I'd concentrate on the developing world, or what some people call LMIC, low and middle income countries, rather than focus on advanced neurosurgery in Australia and other parts of Asia. So I'm going to concentrate on Papua New Guinea as an example of a very poor country that needs a lot of help, particularly in neurology and neurosurgery. I'll start off very briefly in Rwanda, where I served with the United Nations peacekeeping operation there in 1995. And of course, there was chaos there after the genocide. And the Australians were sent in. There were about 305 of us to provide healthcare, primarily to the local people, but it turned out to be, primarily to the UN forces, but it turned out to be primarily to the local people for humanitarian care and surgery. And there were many landmines, of course, and many women and children and men, for that matter, had their limbs blown off. And this poor little boy, who not only lost his limbs, but his parents were murdered, and there was an attempt to murder him as well. So here's an orphan who's lost both his legs. Very typical. And another young child who was macheted in the head in an attempt to murder the child, who miraculously survived. And then I was able to, as a military surgeon, general surgeon actually, to repair the skull with a rib graft and repair his scalp. There are about 22.6 million patients who suffer from neurological disorders or injuries that warrant the experience of a neurosurgeon and neurologist, for that matter, of whom 13.8 million require surgery. Now, to provide that surgery, it's estimated that approximately 23,300 additional neurosurgeons are needed to address more than 5 million essential neurosurgical cases. Is that an impossible dream? Well, not necessarily. It is at the moment, but as we grow the workforce, not only neurosurgeons, but I believe that general surgeons are going to have to do a lot of this neurosurgery. And that's been one of my missions, is to help general surgeons to learn to do basic neurosurgery. Now, as far as P&G is concerned, I asked the question, how can we help develop neurosurgery in this country where there are over 9 million people now, to the north of Australia, one of the poorest countries in the world, perhaps one of the most violent countries in the world, and with shocking health statistics. You might ask the question, is neurosurgery a total luxury? Well, in my estimation, all surgery is essential. It's just a question of how far you go with it. There are many basic elements of neurosurgery that can be done by young neurosurgeons in training and junior neurosurgeons, and of course, general surgeons. We don't need to have the most advanced techniques in neurosurgery to save many lives in these very poor countries. So what do I do when I go to this country? I try and help to show surgical techniques. So that's skills transfer, if you like. It's also knowledge transfer. I try and use the equipment that they have on site. I don't take my own equipment because I show them how to do things with what they have. I show them how to make decisions in surgery, the clinical skills and diagnosis required. I show them how good hospital systems can work and how to improve their system. I show them some basic aspects of infection control, informed consent, medical ethics, medical research and audit, and also, of course, to help them to provide pre-operative and post-operative care and improve their general service. So it's not just a matter of going there and doing surgery. There's a lot of other aspects to working in a developing country. And here I am with the medical stuff. And here teaching the medical students from the University of Papua New Guinea. They have about 50 graduates a year, and they're trained in general medicine and surgery, so they get an MBBS, but they also have a training program for surgeons and physicians. So we have now trained a couple of their general surgeons in upskilling them to do neurosurgery. However, there are many problems in the developing world, the developing countries. There's much overcrowding, there's aging ward and theatre facilities, limited radiology. When I first started in PNG, there was no CT, there was no MRI, just plain radiography, and sometimes even that was lacking. Old and limited range of surgical instruments, shortage of disposable items, shortage of consultant anaesthetists, equipment breakdown and lack of replacement, shortage of drugs, power outages, water supply issues, water purity as well as water supply, drift from the government to private practice, or in fact, emigration, where brain drain, taking the highly trained doctors away to work in wealthy countries and impoverishing the country that they came from in terms of their medical care, and poor paying conditions, which exacerbates the brain drain and often security issues as well, certainly in PNG. So we need to show the surgeons how to do burr holes, not using power tools as we would in the well-developed countries, but how to do it with hand tools like this Hudson brace, and then using the Gigli saw to open the skull is a very standard technique required in developing countries. And if I ask my residents to use a Hudson brace and a Gigli saw, most of them wouldn't know how to do it. Maybe we should be teaching all of our trainees how to use these basic hand tools. Trying to do a laminectomy with hand instruments like these rongeurs is actually quite difficult. And if you have a punch as well, you can do laminectomies without power tools, but it is not easy. There are the three delays in all developing countries: advanced pathology, delays in transport. Often these countries like PNG don't have well-developed roads and transport systems. And then there's overcrowding and delays when the patients reach the hospitals.
No, Professor? Oh,
this
you seem to be
is
lost.
always run. Say, sorry.
Sorry, we lost you for a second, but you're back now.
Oh, sorry.
It's okay.
Well, I go back to that previous slide. The outpatient clinic are always overrun. The common diseases in PNG and developing world are, as you'd imagine, tuberculosis, HIV, hepatitis, pyogenic infection, etc., etc. You can read it there. Even yaws and leprosy are still in PNG, although they've died out quite a bit now. And then the Western diseases are becoming more prevalent because of Western diet. And so we're seeing more of these problems as well. This is the general ward environment, and this is the ICU environment. Not much equipment there compared with an advanced hospital. Now, I'll just give you a few examples of basic neurosurgical care that can be done by junior surgeons and general surgeons, neurosurgeons in these developing countries with limited equipment. an extradural hematoma. Head trauma is one of the most common problems faced by surgeons in developing countries. Draining the extradural saves lives. In this case, from playing rugby, the spine in many of these countries. So in this case, the patient was placed in external skeletal traction with tongs attached to his skull and had to rest in bed for 6 weeks until the fracture healed. Hydrocephalus is really in epidemic proportions in these countries because of post-meningitic hydrocephalus, usually, sometimes congenital, but these problems often present very late and are amenable to shunting, at least in the early stage. Pyogenic infections of the head and neck are very common, in this case, the ear, the middle ear, and the mastoid. Pus coming out of the ear. The patient presents with repeated seizures and coma. And you might think, well, the child will die, but in fact, the child has a large, this can very simple, a good recovery. Congenital problems are also very common in developing countries, particularly neural tube defects, because folate deficiency is very common, and there's a genetic element as well. So these frontoethmoidal encephalocele are very common in the tropical countries, and can be repaired with relatively simple surgery, although the repair isn't as good as more advanced craniofacial techniques. Spina bifida is very common and often requires surgery to fix it. This is a delayed example. Tuberculosis of the spine with gibbous deformity. This young lady had previous surgery and to drain a cold abscess around the spine, but been left with this deformity. And then there are the brain tumors, such as this one. Now here we're getting into more advanced territory in terms of surgical skills, but this is a benign tumor. This is curable. If it's not operated on, this patient's going to die. So shift the mural nodule, which is the active part of the tumor, and the cystic element, which contains proteinaceous fluid. So I showed them how to do this sort of flap, and then to expose the tumor and drain the cyst with this needle. In the cyst, you can see the yellow fluid squirting out of the needle to collapse the cyst, and then removing the mural nodule to cure the tumor. And so at the end of this, patient has the cyst drained, the mural nodule removed, and makes a good recovery. The last case I'll show you is another advanced tumor. In this case, it looks like a meningioma. It's benign. It'll kill the patient without surgery. And so I decided to do an operation with very basic equipment and show them how this type of meningioma can be removed. Completely benign tumor in a young man with a large flap required and progressive debulking of the tumor using suction and diathermy. There is no cavitron ultrasonic aspiration available in PNG, and progressive that the tumor is removed. While I'm removing the tumor, the lights go out because there's an electricity outage in the town, or in the hospital rather. The hospital didn't pay its electricity bill on time, so its power was cut off. So I'm in the middle of the operation with the patient's brain exposed, and this happens. And this is a common occurrence in many developing countries. You have to be prepared for the unexpected. But eventually the power went on, the tumor was removed, the patient made a good recovery. The patient's life was saved. And lastly, as Joshua said, just for those of you who are interested, these books that I wrote with General Surgeon David Waters, who was the professor of surgery in PNG, shows how these simple operations can be done with very basic equipment, and also shows how to diagnose these problems, so that I'm hoping that as more and more surgeons become familiar with this information, that many more patients can be treated and lives saved, so that more neurosurgeons will be trained, and I use the word neurosurgeon in the generic sense that we're dealing with general surgeons here who've trained in neurosurgery and will be able to practice neurosurgery as well as their general surgery in often remote and austere locations, austere in terms of equipment. So thanks very much for your attention.
Wow, thank you so much for that. We really, I can definitely say I really enjoyed it and hope the rest of the audience felt the same way. So thank you for the people who have sent questions in already. So with those questions will have an opportunity to be asked during our first Q&A session. And that'll be after the next upcoming talk. So for the next speaker, I'm very glad to introduce Professor Cherian. He's the Director of Neurosciences at Krishna Institute of Medical Sciences, Karad, Maharashtra, and also happens to be the Counselor General of Asian Congress of Neurological Surgeons, and also a member of the WFNS Anatomy Committee. He represented India in the, He represented India for the UNESCO Neuroanatomy and started cystonostomy, a microsurgical procedure which has changed 100 years of doing simple decompression surgeries for severe head trauma. And due to his passion for teaching, he's very actively involved in the education of young neurosurgeons across the world throughout as a neurosurgery coach. So without further ado, I'm very delighted to introduce Professor Cherian to speak before us today.
Thank you very much, Joshua. Can you hear me?
Yes, we can hear you.
Okay, so I'm going to share my screen. Jeffrey made a fantastic talk. I was enjoying it. And it's true, very, very true that the world, even in neurosurgery, it's unequal. So I'm going to tell you something that, proves that the third world is a mindset. This is what I want to tell you, everyone, that the third world, maybe in reality, if it may not be a mindset, but it starts off with a mindset. So can I share my screen? I'm just sharing my screen right now.
Yep, we can see the screen.
Okay, right. So about 15 years back, after having finished my vascular and skull-based surgery from Japan with Professor Simon, I decided to move to Nepal. So I was there for 14 years till I moved back to India, to Krishna. But all the work we've done starts from Nepal. When I went, I remember working in a hospital. The only things that I had was a bipolar, a not so very well working bipolar, and a suction. And probably Jeffrey can very well relate to it. But then in the end, I was there for 14 years. The last 4 years, I had an intra 3 Tesla MR. I don't think many places in Europe had it. We had the best microscope in the world. We had the best equipped, or one of the best equipped. We had patients from Europe coming down to get operated with us. So we did not want, in 14 years, it's a long time. So we did not want to be limited to who we are. We did not want to accept the limitations and say, listen, we can only do this much. So that's why I'm telling you, to all the medical students who are listening to us, the third world is a mindset. So we will tell you something that we changed. In 2007, we mistook, I would say it's a serendipity, because there were two two cases. One was an ACOM aneurysm and another was a trauma. So we didn't have these fancy phones at that time, you see. We had just those phones where you could send a message at best. There was no pictures or anything. So I got a message. I was in a shopping mall, so I got a message on a Saturday saying that there are two cases, and I was a consultant on call. My junior said, there are two cases. One is an aneurysm, one is a trauma. So as usual, I am probably a bit shameful. It's a bit shameful to accept that I obviously didn't want to do anything with the trauma, because I had finished a lot of traumas as my resident 6 years in Vellore. So I said, let's push the aneurysm first, and then you go ahead, do the trauma. So 1 hour later, I went in, and my assistant was not somebody who was known to speak a lot. Neither was I at that time. So we went in, I saw the brain was very angry, just like an aneurysm would. So I started opening the systems and started looking for the aneurysm that I had seen in the angiogram. Almost an hour later, I figured that I cannot really find the aneurysm. So I was starting to panic a bit. And then I asked my assistant, I can't find the aneurysm. So he said, you know, this is not the aneurysm, this is the trauma. So I probably told him something that I really cannot translate right now in my native tongue. But what struck me was that, you know, the brain had gone really lax, because I had opened the systems. I did not pretend that it was an aneurysm. I thought it was an aneurysm. I was operating on a trauma. And I opened all the systems because that was the way to go. And then the next day, of course, I didn't put the bone flap back, because we were taught, and our thought process was such that we should not put the bone flap back. So I did not put the bone flap back, but the next day, the brain was completely lax. It was something which I hadn't expected. It was a pretty bad head injury. And so I started, so 2007, we started thinking maybe the 100-year-old surgery of decompressive hemicraniectomy is probably wrong. And at that time, I thought it's cystonostomy. We called it cystonostomy, opening systems. I thought it's like, you know, it's like magic. It can work with everything. Later on, we realized it's not so, it doesn't work everywhere. But we realized that this 100-year-old surgery, where a junior resident does a decompressive for every case at the drop of a hat, was probably not necessary. Probably it was a bit outdated, and microsurgery should come into trauma. So this was the beginning of cystonostomy. So I'll tell you a few examples. These are examples. This is from the Dominican Republic. So this is the subdural being evacuated. And you see very soon what happens. That's the brain coming out. It's a common scene for many neurosurgeons in trauma. It's a very common scene. So how did we start avoiding this? That's what I'm going to tell you. So as I told you, I mistook, I'm shamelessly accepting that I mistook a trauma for an aneurysm. And by serendipity, we found something that, you know, changed our thinking. And I was stubborn enough to go ahead with opening systems in trauma for 14 years. And we're going to tell you where it led us to. So these are some of the scans. You can see it's pretty bad head injury scans. One of the oldest patients that we had, over maybe more than 10 years old. This patient was brought with an M2 score. Pretty bad. Cisterns are all not at all seen. So you can see we did a decompressive. At that point of time, we were not doing cystonostomy as such. We were not keeping the bone flap back, because, you know, a paradigm shift is not very easy in neurosurgery. So We opened the systems, of course, we didn't evacuate the contusions as such, but we kept this thin bone flap. You can see a very thin bone flap being kept. And the thing is, the systems were open. And the C, this was the guy, even while he was in the ICU. And there were many cases after that. Over 14 years, we have more than 1,500 cases. And of course, now they are textbook chapters. There are papers from all over. There are trials from Europe. There are trials from China, India, South America. So there are many papers all over. So we will show you that. So these are some of the cases with huge midline shift, hematomas, and the results. So I wouldn't want to kind of focus onto this, but what we started thinking as to why this is so. We didn't know, because people asked us, how does it work? And we didn't know. This was a case where we found the surgery, but we didn't know how it worked. So then we started reading up, we found out that the CSF in the base of the brain, the CSF in the base of the brain, if I ask most of the neurosurgeons, why is the CSF there in the base of the brain? People are going to tell me it's for suspending the brain. And we realized that it's just not for suspending the brain, because we started looking at something called the Verschuren spaces. These are outlets from, I'm going to skip all these scans and all the surgical parts. I'm going to tell you something really interesting here now. So this is the base of the brain. You can see my arrow. And these are all the vessels running into the brain. We figured that from the cisterns, the CSF was migrating through the Verschuren spaces to all parts of the brain. Now, when we started talking about that in 2008 and 2009, people laughed at us. But 2012, the G lymphatic system came to vogue, and then people stopped laughing. But then again, we didn't know why the CSF was going in. We realized that the CSF was going in because of two things. One was the cleaning, which was happening all the time. So how does, so cooling, which was happening all the time, and then cleaning, which was happening in the night. So I'm going to tell you how that happens. It was a crazy theory when we went ahead and hypothesized this. It was a crazy theory. It's still a crazy theory. You see the sinuses? There's airflow through these sinuses. All the time you take breaths, the air flows through these sinuses. And these sinuses are lined with wet mucosa. And what does it do? It's like you wearing a sweaty t-shirt and sitting under the fan. If somebody asks you, why are you sitting underneath the fan? You wouldn't say that you're there sitting there to humidify the room, right? You're not sitting there to humidify the room. You're sitting there to cool yourself. So these sinuses are strategically placed because they're strategically placed around the largest collection of CSF in the base of the brain. And these sinuses, when you breathe, these sinuses are getting cooled up to 3 degrees centigrade, more cooler than the rest of your body. If you take a temperature map, you'll see that the sinuses are much more cooler. And when you see that, you will understand that the CSF is also cooled, and the CSF is being pumped into the rest of the brain through the Virchow-Robin spaces. And how is it pumped in? It's pumped in because the Virchow-Robin spaces are around the vessels which go from the cisterns into the brain, and these vessels are pulsatile, and because they are pulsatile, this CSF is pumped in. It's the Archimedes screw principle. So imagine this is a continuous cooling process that happens. And in the night, the aquaporin 4 channel is open. And this CSF, which is in the Virchow-Robin spaces, goes into the ISF. It comes in contact with the ISF. And that cleans as well. So the CSF is actually a cooling and cleaning pathway. So the brain is actually water cooled and water cleaned. Now, how does this come into system? That's when we realize when there is trauma, there's bleeding into this part. There's bleeding. There's one of the most important tenets of every severe head trauma is a subarachnoid bleed. When there is subarachnoid bleeding, the pressure inside these cisterns, they go up. Obviously, the blood cannot go in through the Virchow-Robin spaces. So the fluid, it displaces into the Virchow-Robin spaces. So that's why if you take a severe head trauma, there's no fluid in the base at all. All the cisterns are obliterated. And what's happened? This 100 ml of CSF is injected into these Virchow-Robin spaces inside the brain. Try injecting 100 ml of fluid into a 1500 ml bottle of Coca-Cola, and you will find how difficult it is and how much the pressure goes up. That's exactly what happens. And what we do generally is try and open a large chunk of bone and allow the brain to swell. This is called decompressive hemicranectomy. By accident, we discovered that if we open the cisterns instead, the results are far better. So this is where we started off. The accident that we had, the serendipity that we encountered was that we opened the cisterns in 2007. We found out that it's far better than opening a large chunk of bone flap and allowing the brain to swell out, which was going on for 100 years. And that led us to the Virchow-Robin spaces. That led us to understand how the brain is cooled and cleaned. And that also helped us to explain what is the physiology behind the brain swelling. We described it, we called it the CSF Shift Edema, which means the CSF in the cisterns gets shifted into the brain via spaces. And that's what we call the CSF Shift Edema. So over the 15 years, what we achieved was that we were stubborn. We had a lot of condescending people saying to us that, oh, it doesn't work, it's nonsense. We started off as entertainers. Then people started getting confused. And then people started taking us seriously, but then they didn't know how it was done. But then now we have so many centers doing it, so many trials which are going on. One of the problems we have in the world is the so-called culture of peer-reviewed journals and p-values. The problem is a lot of neurosurgeons are also shifting into it. I tell you, mind is the biggest lab. Mind is the biggest lab. And if you have a hypothesis and if you have common sense, you can either prove or disprove it. And it doesn't require a lot of facilities to do that. We did all this from Nepal. Literally, we changed. I can't say still we changed because there's still a lot of resistance. And this resistance is because of this ingrained culture of p-value and peer-reviewed. I mean, you cannot peer-review anything which is new because nobody else understands it. Thankfully, the earliest advances in neurosurgery didn't have to be peer-reviewed. Otherwise, I cannot imagine the drill or even the knife being allowed into the brain. The bipolar, imagine the bipolar getting into the brain or the drill getting into the brain. Somebody did something, 5 cases, and they said the p-values are heavily stacked against the drill. So the drill should not be allowed in neurosurgical practice. Thankfully, these guys were not so active during that time. Right now, we have a culture where everything is peer-reviewed, and there are neurosurgeons who doesn't operate but just review, criticize. And I think in the third world, or the so-called third world, we should eradicate this. Sometimes I ask my fellows, how many papers did Lionel Messi write? Or, Lewis Hamilton, how many papers does he have so that he can be considered an expert in the field of racing? It is not the number of papers or pay value, it is the skills as a neurosurgeon, and it is a common sense, it is the childlike wonder that we need. And that's what led us to cystonostomy, that's what led us to Washer-Robin spaces describing Csf Shift Edema, describing how the brain is cooled and cleaned. These are all papers you can see in many journals. This is the experiment, how we proved with Calgary, how we proved the Csf Shift Edema. You can read about all this later on. But the thing that I wanted to tell you, all you my young colleagues, is that sometimes doesn't require a lot of facilities to do things, to change the world, to tell things that, which are not accepted, which will later be accepted later on. But it requires just a childlike wonder and a lot of stubbornness and technical skill, of course. I mean, in neurosurgery, I believe there's nothing more than, Jeffrey was showing how important it is to start off from the basics and then build it up. So today, these are all the indication scores and all published. And let me show you the papers that we've had. So all the papers in World Neurosurgery. This is the Swiss group. They did the trial. So the Genos accepting cystonostomy is one of the options for head injuries. The criticisms, we believe the criticisms are because it's difficult for anybody to change. And this is in the Springer Neuro series, how we explained how this theory goes ahead and explains the CSF shift edema as well as the cooling and cleaning functions of the CSF. I'll stop with just one sentence. More than what you think right now is research. What you need is a completely open mind. And wherever you are, you may be in Nepal, you may be in Africa, you can do equally good research. And you should realize that third world is in the mind. It's not a physical barrier. You can change the world from wherever you are. Thank you very much.
Thank you so much, Professor. Really enjoyed the talk, especially that ending phrase about being able to do quality research no matter where we are and not to be limited by our environment. I really appreciate that. So we do have some questions that people have answered in. I hope that's okay for you two if you'd like to answer some of them. The first one that came to me, and this was during the first talk, was how can we address some of the problems that were mentioned in delivering neurosurgical care? So this was, this question came from the talk with Professor Rosenfeld. How can we address some of the problems you mentioned in delivering neurosurgical care?
Yeah, thank you. Look, it's difficult, but in fact, the World Health Organization has made big inroads into trying to improve surgical services in the developing countries, and they've set out, what are the basic services that should be provided, and they've asked the countries to provide their data so that they can try and influence the developing countries to put more resources into their surgical care and anesthetic care, so that it's a bit like shaming them and comparing them out in the open to other countries to try and get them to up their game. As you know, in many developing countries, there's such a wastage of money on things that are perhaps not as necessary as healthcare. And healthcare is a human right. It's something that should be provided. Basic healthcare should be provided by a government, but it's in many cases it's not. So it's a matter of lobbying, gentle lobbying from world organizations, but also gentle lobbying from inside the countries themselves by senior clinicians and professors and administrators who can gently persuade health officials and administrators and health ministers to devote more of their, or indeed prime ministers, to devote more of their budget to basic health care, but also in that basic health care is included surgery and anesthetic care and maternal care to reduce maternal and child mortality. These are just basic human rights. We must strive to improve this worldwide. Some countries have such a long way to go, like PNG, for instance. Others are more advanced and probably closer to the goal of providing, more basic health services. But there are still many countries that are not providing it. And training opportunities are also an issue in these countries. Training quality and training numbers in various specialties. And this compounds the problem. So, that's a brief answer to a very difficult problem, but hopefully it's given you some ideas.
That was a great answer. Thank you so much. So I have another question that came in during Professor Cherian's talk. And they wanted to know if induced hypothermia can also help in addition to opening paranasal sinuses.
Yeah, interesting question. We've been working on this. It's interesting when you see that if a patient is intubated, there's this thing called a shunting effect, where because the breathing, the sinuses are being cooled and that cools the brain. And when you're intubated, actually the brain's temperature goes up. So that's interesting. So this is called a shunting effect. So we were looking at ways where you could actually, instead of complete hypothermia, this hypothermia papers now, they have not proven of clinical benefit, but we were thinking if we can have a selective hypothermia of the sinuses, which means if you could have a balloon and a countercurrent I mean, if you introduce ice cold or maybe 15-degree saline and then take it out into a balloon which can fit into the sinuses, we could probably keep up the cooling. So this is something that we're trying to research on. We don't know whether it would work. People have tried hypothermia and it is not really shown to be of much clinical benefit as of now. But this is something that we're planning to do, and then we don't know what it will lead to.
Thank you.
Can I
Sure.
congratulate Dr. Cherian on his innovative ideas? It's very difficult to change the paradigm, as he says. It not only takes a lot of imagination, sometimes serendipity. In his case, he started off finding it by accident, and then he worked out how it worked. And that's a great way to go. Many advances in medicine come by serendipity initially, but then he had the courage to develop it further and persist and promote it despite all the detractors and the critics who were trying to stop him doing it and saying it's a waste of time. But he persisted, and I congratulate him for that. And it's tremendous achievements what he's done.
Thank you. I'm very honored, Jeffrey.
We had so many questions come through. I'm so sorry we can't ask them all. We have maybe just time for just one more question. And I'm just going to combine two of the questions that we had before. So they were wondering, what are your opinions on institutes for pursuing neurosurgery residencies? For example, pursuing a residency in the Western world, if you wanted to work in a developing country. And if a medical student, I'm guessing it's a personal question, if this medical student had a trauma history and was unable to stand for a long time for surgery, is this something you feel like would demotivate somebody, or would you think they should still be able to go for neurosurgical training?
Just from the first question, I didn't quite understand the second question, but the first question, if there is a neurosurgery training program developing or developed already in your countries, it's best to train locally if you can, and then perhaps take a fellowship in a more advanced center overseas. But please go back to your original country because they need you. With that training and that knowledge, you can do so much good in your own environment. So I plead with young neurosurgeons not to be part of the brain drain, and please get the advanced skills, but come back to advance neurosurgery in your original country. So there are many good institutes developing for neurosurgery training in Africa. You'll probably hear about them later. Certainly in Asia, in China, in India, there are so many places where you can train in surgery and neurosurgery. You don't necessarily have to go to England and America, at least initially. So I think there are so many different opportunities, and you should do a bit of detective work so you can work out where the good places are to go. The second question I didn't really understand. The person had a head injury and they are wondering whether they should do neurosurgery. Is that what they said?
Yeah, so they said that they have like a trauma history and they're unable to stand for a long period of time. So they thought this might be difficult for surgeries, but they wanted to know if they think this is something they should still continue going for, because they feel demotivated at the time.
Well, I know there are some neurosurgeons who've become paraplegic and they're in wheelchairs and they still do surgery on an elevated chair. So being disabled, at least in the lower limbs, is not a reason not to do neurosurgery. But certainly you have to have two good working upper limbs and good eyes, so you've got good eye-hand coordination, and so it's not a bar having difficulty standing, but neurosurgery is and I'll be interested to hear what Dr. Cherian has to say, but neurosurgery requires mental and physical fitness. You're often asked standing for long periods of time over someone's open head or open spine, and that requires a lot of physical stamina and physical fitness and endurance capabilities. For someone who has difficulty standing for any length of time, they might find it challenging to undertake, neurosurgery as a career. I'm not saying they shouldn't, but they're going to find it challenging. Maybe a better option for them would be to choose neurology, for instance. Anyway, that's just a suggestion.
That's absolutely fine. Thank you so much, you two, for the talks. Especially, I know the time zones, it might be pretty late for you, Professor, but
not a problem.
Thank you so much for everything, and really appreciate your time today.
Thanks for having me.
No problem at all. So for our next speaker, we have Professor Servadei. He graduated in medicine at the University of Bologna in 1976, cum laude, and completed his full training in 1985. For 27 years, he was the director of neurotrauma and emergency care at the Bufalini Hospital in Cesena between 1990 and 2007. And for the succeeding decade, was the director of neurosurgery and neurotraumatology at the University Hospital of Parma and Reggio in Emilia. He's now a full professor of neurosurgery at the Humanitas University in Milano, Italy, and is the immediate past president of WFNS as of last year. Invited speaker in the last 10 years to international meetings in all of the 5 continents of WFNS. And without further ado, I introduce Professor Servadei.
Okay, thank you for the kind introduction. And I have seen the previous speaker with interest, and I'm now going to share the screen to show my presentation.
Yep, you can see
okay.
the screen. Yep.
Yeah, perfect. I just go back to the first one. Okay. I have a slightly different presentation from the site of Global Neurosurgery, as it is from the view of the World Federation, where I did work as president for 4 years, and as it is from Europe, where do I live. We have about 50,000 neurosurgeons all around the world, but obviously there are big disparities in the distribution of the neurosurgeon. As you see, we have a lack of neurosurgeons in Africa and Southeast Asia, and probably we have more than we need in many Western countries. That's nothing new. This is the distribution of surgeons, obstetrics, and anesthesiologists. And as you see, is a complete parallel with neurosurgeons. So there is no difference between distribution of neurosurgeons and other surgeons. We have distributions, disparities in instruments, and I give you an example. This is an overview of the available instrument, and as you see, in low middle income countries, only instruments to operate trauma and spine dysraphism or abnormalities like hydrocephalus are available. Most of the other instruments are not available, and I give you a practical example. This is the publication we did about the use of the isoscope for surgery, for cranial surgery, for tumors. The same authors of this paper went to operate in Benin in Africa, and then they used the telephone, the smartphone, as a microscope. So the same authors that in Europe published about the isoscope use the smartphone as an isoscope. So we do have disparities, which is, in my opinion, one of the most important issues in publications. This is the first paper we wrote in 2019 about the reports and publication in neurosurgery from low and low middle income countries. as we are speaking here to students, there are 2 medical students among the authors of these papers. And as you see, there is only 5% of the neurosurgical publications are coming from low and middle income countries. And out of these 5%, 3/4 come only from 2 countries, India and Egypt. So we do have basically very few publications from low and middle income countries, and most of them are related only to 2 countries. And as you see, these are the most publishing countries in the world in neurosurgery. And we have United States, China, and most European countries. The only country from low and middle area, it's India, who is number 13. So you see that, and if we look at the most cited papers, you see it here, the most cited papers are, as you see it here, in traumatic brain injury, the most cited papers are here and are related to Western countries, America, Europe, China. And if we look at the same disease, this is traumatic brain injury, this is the occurrence of the disease. So we have one part of the world where traumatic brain injury is extremely important, but the publications are coming from the other part of the world. So it's really difficult to combine this. And if we compare the capacity for publication with the incidence of trauma, you see that in US, we have such a number of publications, but the incidence of trauma is about 1/6, and in Europe is similar. Whereas in Africa and Southeast Asia, we have a lot of traumas and very few publications. What does it mean? It means that if we move to randomized clinical trial, very few of them are done in middle or income country or little or low income countries. And the generation of guidelines, in this respect, I agree with Cherian. The guidelines that we publish are generated by randomized clinical trials, and randomized clinical trials are done in one part of the world. So what we generate is a set of guidelines which are applicable in high-income countries, and we have difficulties to apply them in low and middle income countries. And this is why we do probably need different instruments to include low and middle income countries in the production of consensus and guidelines, like, for instance, the use of consensus conference, as you see it here, which is available for spine, for tumors, for trauma. So wherever we do have the necessity to work with countries with limited facilities, we cannot use the system of evidence-based medicine because these papers are not generated where the country needs advisors. And the other issue is clearly to know the available resources. This is the paper published in Focus about training of Sub-Saharan African neurosurgeons. And as you see in this slide, most of our colleagues in these countries have used both cranial and spine surgery. They have a caseload which is in a way limited as compared to Western countries. Most of them are doing both elective and emergency surgery. But the most important is access to NMR, which you see is limited, and also access to microscope is surprisingly limited, and to endoscope. So what we have is a totally different situation where we do have a limited access to instrument, that in Europe, in America, or Australia, we consider, let's say, indispensable for our work. And also, since we are talking with students today, there is a very nice paper published by our African colleagues saying that if we have a rotation of medical students in African countries in neurosurgery, we generate more interest and more neurosurgeons. As you see it here, this is a survey of over 500 students in African countries, most of them very young students. And as you see, students with a rotation capacity were more and more aware of the neurosurgery duties and work, and were more interested in neurosurgery. So we do have the possibility to increase the number of neurosurgeons in countries with limited facility just by including a rotation in neurosurgery within the education in African university. How can we help our colleagues? This is extremely important. As you see it here, we have to, how do we help our colleagues? First of all, we have to know what's going on there. I mean, I have seen papers telling we can avoid monitoring by repeating CT scan. In most African countries, you cannot simply, or Southeast Asia, you cannot do it because CT scan is an expensive tool. Or we have to do a follow-up at 6 months. Also, this is impossible in many countries. So the first issue is recognize what we can or we cannot do, like the global neurotrauma outcome study, which limit, for instance, the outcome at the discharge and not at 6 months or 1 year, which is impossible in many countries. Or we do have what we call it a twin university system, which is a system of collaboration between Western university like US, Europe, Australia, in some cases China, in some other cases even India, where with a system of collaboration called the twin university system. I give you an example here. Again, many medical students are involved in this project. You see it here is a joint collaboration between the Cornell University in New York and the Moi Institute in Dar es Salaam in Tanzania, which resulted in a series of publications about head injury and spine injury. So this is a typical example of important collaboration between Western university and African university. About Europe, which is the feeling of the European neurosurgeons versus collaboration with countries with limited facilities. This is a paper which is going to be published soon in the Journal of Neurosurgical Science. It's a survey of quite a number of neurosurgeons in Europe from 40 different countries. And we ask them, I mean, which has been your collaboration with countries with limited facilities? And as you see, many of these neurosurgeons have traveled to Africa. Some of them have traveled to Asia. Many of them have already collaborated with institutions in countries with limited facilities. So it is in Europe, there is already, let's say, a base for creating a good a stable collaboration between countries with more and countries with less facilities. And most of the European neurosurgeons are willing to pursue and to go along this way. What did we did before the pandemic for education? you see that we had a classic format of education all around the world with congress, meetings, courses, cadavers, exposure to cadaver surgical work. I give you some quick example. This is Africa. And in this specific African training, also students were involved in the training for in Kenya. Or innovative form of like 3D cinema lectures. This is Indonesia, where you see that there was a master, Professor Spethler, giving lectures in a cinema with a 3D system. Or after the pandemic, we had the increased use of forms of education which were already in place before the pandemic. This it's a paper that we published together with our colleagues in Cambridge 2018, before the pandemic. And these are some of the institutions who support continuously web education for neurosurgery. We already had, before the pandemic, many webinars. Obviously, after the pandemic, it became endemic, like the pandemic is an endemic use of webinars. You see it here all over the world. And what we miss in the webinars is probably the cadaver dissections, that obviously we cannot do it. We do have some forms of education via simulation, as you see it here. We have in my city in Milano, in another institution in the Besta, one of the largest simulation centers in the world, but simulation needs also machine for simulation need the in-person use. And we have also instruments like this is called UpSurgeon, is a European platform based in Italy, but diffused all over Europe, where we can use education via web as a simulation of surgical approaches, anatomy, everything. And as we said, there was a survey promoted by Professor Kipark and Professor Al-Awabi asking to countries with limited facilities, what do you want after the pandemic? And most of these people, as you see it on the right side, ask to continue to virtual labs and to continue with the collaboration with high-level Western societies. Where before I just also taking part of the presentation of Cherian. There is a weakness in the internet learning. The weakness is that there is no quality control. Remember that every surgical approach can be posted in the web. In YouTube, there is no control. And there is nothing about the learning curve. We are surgeons. We know that to use a technique properly, we need the long learning curve. If you watch a video, in the video, there is nothing about learning curves. And the social communication may sometimes take a wrong direction. This is a paper about Neurosurgical Cocktail, which is the largest social platform in the world. It's about 35,000 people connected with this social media. I don't think all of them are neurosurgeons, but surely most of them are neurosurgeons. Most of them are coming from India, Egypt, and Brazil. Again, the issue of low and middle income country, the two countries with more participants in anything are India and Egypt, as you see it here. And basically, this it's important is a base of discussion for difficult cases. Like you see it here, I give you an example. This is a guy from a country with limited facility asking in the web, what should I do with the case that I have not seen frequently, which is important. So there is one side of this social media use, which is important. The other side, as you see it here, is probably wrong or misdiscussed. When I fully respect the work of Cherian, but as you see it here, there is a wrong discussion. The discussion is the great neurosurgeon is one who publishes, one who does many surgery or teach and speak in conferences. As our magister, as we say in Latin, our teacher, Harvey Cushing said almost 100 years ago, surgery is not only skillless, but also the possibility to publish and teach. And this is important. The two things are not in contrast. Obviously, we cannot be against innovation. This is wrong. We have to accept innovation, but we cannot be against publication. We have to combine it. It is difficult, we all know it, but we have to improve the possibility to publish our data and combine them with the good routine work. And just as a criticism to myself as first, as living in a Western country, the publication capacity in low middle income countries, the target is not the increasing on the impact factors in our countries. The increasing of impact factor in Western countries can be only a secondary effect. The target is improving the capacity of working, of education, and of publishing in countries with limited facility. If we look at this paper with going into the 50 most cited global neurosurgical papers, you see it on the right side. These are the authors most cited. One of these is me, so I am included in this criticism. You see it here. Almost all of them are from Western countries. So when we write about global neurosurgery, most of the authors are coming from countries with high-level facilities. And again, as a student, you must be, let's say, proud that out of these people who has been the most cited papers in global neurosurgery, 4 of them are students. So we do have 4 students as the most publishing neurosurgeons. And if we look at this data that we are going to publish soon, and this is data collected by students at my university, there is nothing changing between 2017, 18, 19, 2020. The publication, the number of publications in low and middle income countries did not increase. The only one where there was an increase is India, who is, again, I'm telling you, it's representing over half of all the publications. So just to finish my presentation, a Latin poet, Seneca, said, si ospem a cena invitamus, ipse debet cibum diligere, not isquid cocit. If we invite someone for dinner, he or she needs to like the food, not those one who cook it. So the question is, the Western institution, including me, and I am really very critical about the way how to do it, needs to prove that we have reduced the disparities. We have increased the publication, we have increased education, and we have, let's say, talking to students, we have improved the quality of our students going to learn neurosurgery, and we have given them the way to do it in collaboration with us. Thank you so much, and Happy New Year from my country.
Thank you so much for that amazing talk, Professor. Unfortunately, we are running a little bit behind schedule, so I'm just going to move on to the next speaker. And unfortunately, we won't have time for our Q&A session either for these 2 speakers. So for our next speaker, I want to introduce Dr. Eurek Kanmounye. He's a postdoctoral research fellow with experiences at Harvard Medical School, Operation Smile, Kasinga Health System as well. He's the founding president of the AFAN, or Association of Future African Neurosurgeons, an interest group for aspiring African neurosurgeons. And in this organization, Dr. Kanmounye has mentored students from all around the world building research capacity, and has coordinated multiple research projects in addition with NANSIG as well. He has published extensively on neurosurgery, global surgery, and medical education, and is an associate editor of the Journal of Global Neurosurgery and social media editor of the Journal of Neurological Surgery, the Part B score base. So without further ado, introducing Dr. Kanmounye.
Thank you very much. I will dive right into the presentation. Obviously, it's a pleasure to be here, and definitely a challenge following Professor Servadei and Professor Cherian. I have to say that they've done a really great work laying the foundation for our presentation and giving some elements of what we see as challenges for global neurosurgery and neurosurgical care in Africa. So our presentation really will be about what next, what solutions are we proposing, and how do we intend to get to the goal that we've set for ourselves, which is basically increasing access to quality, safe, and affordable neurosurgical care in Africa. I have no disclosures. A little bit of the background, because this is important on when we will get into the discussions, the different questions, as well as the potential solutions. So Africa really is 30.3 million kilometers squared, 54 countries and 5 major regions, which we see here with the different colors. And if we compare that to Asia, Europe, and the USA in terms of area, we see that the continent is somewhere between Asia, Europe, and the United States. And even if we were to combine Europe and the United States, would still be twice the size of those two areas. And then when we look at the demography, it is 1.3 billion people on this landmass, and a projected increase in the population of 37% by 2050. What that means for us is that whatever challenges we're facing now, if we do not act, we're going to face even more difficult challenges in 2050 and forward. And then comparing that population to the other continents, again, we see that Africa is only lagging behind Asia. And then finally, if we're looking at from an economic standpoint, these are not perfect metrics, but they definitely give us a sense of what Africa is like from an economic perspective, the GDP as well as the GDP per capita. The GDP per capita is more interesting, 1,860. And unfortunately, despite having a large area and population, Africa is lagging behind for the GDP per capita. Why is this important? What this means is it translates into how much money, how many funds are available, first of all, for taking care of the continent in general, the basics, obviously health, education, infrastructure, and really emphasizes the sense that there are competing priorities on the continent. And these competing priorities require that whatever innovations we come up with, they have to be mindful of their costs. We have to be mindful of the cost of these innovations. So the problem has been articulated prior. 9,000 African neurosurgeons are needed, and each year we have a caseload of about 2 million cases. If we're talking about 9,000 African neurosurgeons being needed, it's because of all the different components of the health system. Perhaps one of the most impactful and easy to intervene on is the neurosurgical workforce. But when we look at this neurosurgical workforce, the pipeline is leaking. We had a lot of information from Professor Servadei about some of these issues, but looking at the start of the pipeline, most medical students on the continent interested in surgery are actually interested in neurosurgery. However, they do not have the opportunities to be engaged and exposed to neurosurgery. So it becomes almost like a fantasy when you say you want to do neurosurgery in most cases, because it's like, yeah, you want to do neurosurgery. We've never seen that around here. Or how do you do that? How do you make that happen? And so we lose some of that interest. And then the next thing is, even those who are interested are not necessarily aware of the opportunities to train on the continent, or even how to get to do it. Those who are aware about the opportunities on the continent often do not have the finances to go into training, because almost every training we have on the continent requires some form of financial investment on the part of the trainee. And then those who get the training face similar challenges when they get into fellowship. And then when they return, there's always a challenge that they might return to a service where they have to build everything from the ground up, or they might find themselves in a situation where the local neurosurgeons are not ready to accredit the training for fellowship. So there are a lot of challenges really to increasing the neurosurgical workforce in Africa. But when we look at the workforce, it's really the tip of the proverbial iceberg. The iceberg is so much bigger. We have issues with information management, lack of information to get a good glance of what's happening, whether that's granular information or more recent information. Infrastructure is lacking, like we've heard. There's issues with governance and funding. We mentioned the competing priorities. And finally, there are issues with the service delivery and the disease burden. When we say that 9,000 neurosurgeons are needed to take up the 2 million case loads, we understand that the neurosurgeon, the African neurosurgeon currently has so much to take care of from a clinical perspective that it's really difficult for that neurosurgeon to go into research, for example, or to go into advocacy to make sure that they get the health system strengthened. So all these things make for, some people would say a dim picture, a grim picture. Others would say it's a window of opportunity. And moving forward, when we talk about global neurosurgery, there are a few questions we need to ask and get answers to. And this is definitely the platform to put out those answers and questions. So the first one would definitely be, we are training neurosurgeons, right? We are training neurosurgeons thanks to initiatives like the ones started by the World Federation of Neurosurgical Societies through accredited centers that have scholarships for some of the neurosurgeons. We are training neurosurgeons through regional training centers. The question now is, where should these neurosurgeons be posted? Because the situation right now is most of our neurosurgeons are in urban areas. Most of the African population is in rural areas. Are we going to send some neurosurgeons to the rural areas knowing that they will not necessarily have access to the basics to take care of these patients? Are we going to send everyone to the urban areas? How do we strike that balance? And this is really where we need evidence-based information to answer those questions for each country. The next question we need to be able to ask and answer is, when we're training our neurosurgeons, are we opting for generalization or specialization? So are we training our neurosurgeons to be able to take care of mostly the emergency cases? Or are we thinking about training them so that they have the the clinical prowess of Dr. Servadei or Dr. Cherian? Well, most people probably answer that we have to strike a balance once again, because if we train general neurosurgeons only, then the more complex cases will not be able to take care of them. And we now have to ask the question of, do we create centers of excellence? Where do we create these centers of excellence? Is it going to be in every single one of the 54 countries? Probably not. We'll probably be thinking about regionalization in the sense of having centers of excellence for each of those 5 regions. But then there's another challenge. That's why we have to be aware of the African situation, which we exposed earlier. Travel within Africa is an issue. It's actually even more expensive usually to leave from one African country to another than traveling to India or to Europe or to Africa or to America. So that is definitely an issue. And so from a neurosurgical perspective, health systems and health policy, answering this question will really go down to what are the objectives short and long term, and what are the capacities available. And then the next one, which definitely goes with this one, is if we are opting for, say, specialization or concentration of neurosurgeons in urban areas more than the alternative, then what is the role and how do we regulate task shifting and task sharing? Because if in the rural areas we don't have our neurosurgeons, then someone needs to be able to diagnose these patients and send them to the neurosurgery centers. And that's where we need to have not only existing task sharing and task shifting, because it exists in almost every African country, but an actual policy around that, around the training, around the referral patterns, which in most cases we do not have right now. And like we said, workforce is only the tip of the iceberg. We have to be able to acquire and maintain equipment to be able to deliver care, which is a challenge. Unlike in other countries, what we see often is the situation where to acquire equipment, they are either donations or we have to go outside of the continent and get this equipment. So they come back, they return very expensive, or it's quite difficult to maintain because there's not the technology to take care of that kind of equipment. And then like we mentioned, we have to define and invest in centers of excellence. And all of these requires generating evidence and value for Africans. So some of these questions, we started answering them through the Association of Future African Neurosurgeons. So that's a medical student interest group that's working to help students get that pipeline from medical school into neurosurgical training and finally onto the continent by exposing them to some of the realities that exist on the continent, because we realize that having a technically gifted neurosurgeon in the African continent is unfortunately not enough, because being technically gifted does not resolve the other issues around the system. It doesn't answer some of these questions. It doesn't help patients get to that neurosurgeon center. It doesn't help with getting the outcomes that are required, because the patients often come in a delayed fashion. And so it's almost an uphill battle for the neurosurgeon in that case. And our aim really is to not only ask questions, but definitely find solutions. We've started finding solutions with some of our publications, and we've implemented some of those solutions, and we're working with institutions to answer those solutions, to answer those questions. We're running behind schedule, so we've tried to cut the presentation short. These are our references, and we'll leave you with this comment. That we need to think of the health system as one with numerous components, and these are all interdependent. And whatever solution we're finding for the continent has to be comprehensive, has to be contextual, and has to be continuously updated. Thank you very much.
Thank you so much, Doctor. Really appreciate it. And thank you for keeping to time as well. That helps a lot. Thank you. Sorry about the Q&A. We won't be having the Q&A session for session 2, but if any of the speakers are still available, we can do that as a part of session 3 as well. So thank you so much for everyone that's gone so far. And for our next speaker, we have Dr. Rubiano. So Dr. Rubiano is a Colombian neurosurgeon who is dedicated to clinical practice and research in trauma, emergency care, neurotrauma, and intensive care. He has worked in research on trauma care and global health promotion with international medical societies as a member of the WHO Committee on Emergency Care and Trauma since 2007. He has participated in several research projects with the aim of developing capacities, trauma care and neurotrauma in low and middle income settings. Since 2005, he's been the medical director, educator, and researcher of the Meditech Foundation in Colombia, training emergency medical technicians and graduate doctors in advanced trauma care. Since 2007, he has participated in trauma quality improvement activities with WHO in low and middle income countries, especially in Latin American countries. In 2015, he began collaborating with the World Health Organization Global Initiative for Emergency and Essential Surgical Care, promoting safe surgical care for low and middle income countries. So without further ado, I would love to introduce Dr. Rubiano.
Hello, everybody. Thanks for the kind invitation. I think this is an amazing meeting, a lot of interest, and I think there have been discussed a lot of interesting topics, especially the one that is related to education in global neurosurgery, because I think that has been the key center issue discussed by all of the previous speakers. So I'm going to mention briefly some of the experience for the activity that we have in Latin America related to global neurosurgery. And additionally, I'm going to end with some discussions related to specifically issues related to education in global neurosurgery. Okay, so just to remember that we are just a few months ahead from the World Neurosurgery Congress, and it is that everybody can arrive for the World Neurosurgery Congress. We understand that we are in difficult times due to the pandemic, but Latin America have been doing a lot of efforts in order to host the activity in person. As Dr. Servadei mentioned, we are full of online activities. And definitely we are eager to start going to face-to-face activities, as this type of face-to-face interaction definitely is not all the time exchangeable for the online activity. So hopefully we can have a really nice event, and hopefully we can host many of the global neurosurgery activities that we have scheduled for this program. So there is no conflict of interest for this presentation. I think the essence of global neurosurgery is all related to the Human Developing Index and the global burden of diseases. We understand that this new metric related to how education and also economic support affects the main care pathways for all the diseases around the world. And we understand now that there are some of these specific diseases that have been creating a big burden in some specific regions, like the Latin American region, African region, and Southeast Asia region. If we go for the specific parameters related to the Latin American area, we understand that for neurosurgical diseases, in general, in all the population, including males and females in the region, the biggest burden is for trauma, that is represented here in the green blocks. So if you compare that with a stroke, or even with brain cancer, or congenital diseases, or Parkinson's, things like that, definitely the biggest burden is trauma. If we move for a specific group, that is the group related to the most active economically population, specifically the young one, you see the huge impact of trauma in the whole population in the region. So this is very significant, and you can visually evaluate the impact of the trauma as disease in the region for all sexes, for both sexes, and especially in the younger population. If you see the distribution around the countries of the region, it's almost equally. The biggest impact, obviously, is in males, because most economical activities has been led by males in these regions. But now, as female are participating also actively in economical activities, it has been increasing also in females. So it's something that is straightforward all around the region. If you go for the population between 15 and 49 years old, it is the same. The panorama is the same. You have the huge impact of trauma compared with stroke or brain cancer or epilepsy. And this is something that start answering some of the questions that already just mentioned, at least for the African region, and say how we can distribute our neurosurgeons, how we can distribute our center of excellence, where do we need to put that, which diseases we need to tackle first. So for that population, you see as again, the distribution is transversally all around the countries, and more focused in male patients, but at the end, this creates a very important impact. This only change for very elderly population, especially more than 70 years old, where obviously a stroke remains as the leading cause, but still there, you have an important group of patients that are suffering for trauma. So fortunately, in 2016, in one of the international conference for recent advances in neurotraumatology, The Bogota Declaration on Global Neurosurgery was born, and that was the official engagement of the World Federation of Neurosurgical Societies within the global neurosurgery community or global surgery community with the World Health Organization. So we see here many of the pioneers, Dr. Park, that definitely lead with Dr. Johnson and push all these declaration about how it will be very important that neurosurgeons around the world take action over global neurosurgery items. We have also Professor Servadei here, Professor Andrew Mas, Professor Osorio, and some of the leads, local and international leads for this movement of global neurosurgery around the world. So I think all of the persons that are interested in global neurosurgery really need to read these points associated to the declaration specifically for neurosurgery. And as I mentioned before, all of this is related to the development index and the global burden index. The idea is to improve all aspects of neurosurgical care whenever and wherever is needed. And we call on action for neurosurgeons are the professional societies of the world and related stakeholders to take urgent coordinated action to lead and address the unmet global neurosurgical needs. So in the region, we have been leading many of these activities from Colombia. What we have done, we are starting with many of our students and also with many of our colleagues from other specialties to understand the situation in global surgery in general in our country. This is one of the articles that we issued the group from Rogers Medical School and many institutions from Colombia evaluating what is happening actually with the healthcare system in Colombia. We have been mapping all the difficulties and barriers for access, also how many of the main specialties are just in some of the main cities, but many regions of the country still remains with a lot of needs and a lot of difficulty for access, especially emergency surgical care. We are focused on emergency surgical care because the other care can be easily managed. The non-urgent operations can be easily managed in specialized centers. I already mentioned people that still have time to be transferred by any means and still arrive on time for a definitive surgery. Like, for example, cancer surgery, many other related surgery for non-emergency conditions, you know, like many operations that can be done by functional neurosurgery and other stuff. But we are talking here about vascular conditions. We are talking here about trauma conditions and some pediatric conditions that needs emergency surgery. When we move for specific issues inside the country related with neurosurgeons availability, we still have 6 states that didn't have a neurosurgeon in all the states. That means a population of near 2 million people. It's not bad for a country with around 50 million people, but still we need to move some neurosurgical workforce to these areas. It is important to know that moving these neurosurgeons need also moving other specialties like critical care, like anesthesiology, because definitely it is important to have the entire team there working. And we correlate this with the local burden of disease study. You see in the map, the blue states are the states with higher burden of trauma inside the country. You have the green states that are the states with more chronic diseases. The yellow states are the states with more infectious disease related conditions. And you see the orange states that are the states with more morbidity associated with maternal and pediatric health. So we have been very active engaging the young generation of neurosurgeons, especially from medical students that have been creating group of interest in neurosurgery from many of the different universities around the country into the Global Neurosurgical Action Plan and also the Global Neurosurgical Activities. We have been mentoring them for many years since now, and many of them actually have been really successful in supporting the research activities and also moving for as medical students for neurosurgical residency. One of our early programs has been the Neurotrauma Global Neurosurgery International Fellowship that is based on all these discussion that we already have related to the importance burden of trauma in the country and especially in the region. We have been very successful how many other neurosurgeons, not only from the Latin region, but also from Africa and Southeast Asia have been applying for participating in this program. We now have more than 12 fellows graduated from the program. We have been receiving continuous application for many different countries around the world. We publish our experience recently, and all the people that is interested in how we move and how the program is, how you can apply, can go directly to this open access study in order to evaluate or see the conditions that we are generating. One of the elderly programs in the regions is from Dr. Hildo Acevedo from the city of Recife. They have been collaborating in his center with African neurosurgeons for many years, since the early 20s. And definitely, they have been very successful, and they have continued moving with these programs. I am very proud to announce that we have our second Global Neurosurgery Fellowship for the Latin Caribbean region specifically. It has been a very interesting collaboration between our research center, Meditech Foundation, and Universidad del Valle in Cali, Colombia. This has been created as a very comprehensive one-year program for neurosurgeons, especially from the Caribbean and Central American region, that can assist to this comprehensive program related to most of the common conditions that are needed in the region. And finally, for talking about education, we just recently this week have been released this publication from Dr. Isabel Germano about neurosurgery and global health. And we wrote a chapter related to the neurosurgery education in Central and South America. And I think one of the main discussions that have been centered in the previous speakers is related specifically to this point, is that the strengths of the actual model of training that is competency-based is the capacity for internationalization and the possibility of allowing the flow of students and professionals from one country to another in order to validate degrees according to the international criteria. But however, this model tends to generate certified students with an accumulation of competencies, so they have the efficient and effective job performance without reinforcing the humanistic and professionalist competences that we all require to lead and take difficult decisions in complex surgical cases, especially in areas where resources are scarce. We all have been going around with all the discussion is just centered in this consequence of this actual model of training. And I think the online education is enhancing the actual model that is just focused on how we can prepare a crowd of people in order to respond for a specific jobs related to manage all these diseases. But we are losing the opportunity to increase the humanistic and professionalist competences that are not really related to the technical work. And I think the only condition or the only real aspect that we have is having all these people be guided by mentors that already have a huge amount of these humanistic and professionalist competences. Because if not, we will continue around the cycle of creating these really good technical performance, tackling these diseases, but not going beyond all that with all these issues associated with the human developing index that we just mentioned. So I just want to thanks again for the invitation. And this is something that we have in our research center website, that is that emergency care is part of a discursive regime of immense social importance in which those who live and die are measured. The political weight of medical science interacts over the debate about healthcare provision in any society, And this debate, with symbolic significance for any caring society, have political relevance and huge economical implications for the members and administrators of that society. So definitely health education and research are fundamental elements to build appropriate well-being and social development in societies, and mostly if they are based in these humanistic competences and developing professionalism at the center of the practical of the exercise. So thank you so much.
Thank you so much for that amazing talk. Really appreciate that, and I hope everyone learned a lot from that as well. So just in the interest of time, we have a final speaker for today, Dr. Rousseau, who is a clinical professor at the neurosurgery at George Washington University School of Medicine and Health Sciences in Washington, D.C. Her areas of expertise include pituitary and skull-based surgery, microvascular compression syndromes, and stereotactic radiosurgery. Her clinical practice is focused on veterans, particularly in the area of traumatic brain injury, and she has over 100 peer-reviewed publications and has been invited as a visiting professor at over 20 institutions. She has been involved in global neurosurgery all of her career and is a leader in the global surgery movement. She has also served on the executive board of the World Federation of Neurosurgical Societies Foundation, so the WSFS, and currently serves as an officer of the G4 Alliance, Surgical Obstetrics, Trauma, and Anesthesia. She has long served on the board of directors of the Foundation of International Education in Neurosurgery, the FIENS, and of Think First, the International Head and Spine Injury Prevention Program, and she has also been elected to leadership positions in the society, the Neurosurgery, the Langue Française, so SNCLF, WINS, WFNS, and the American Association of Neurological Surgeons, AANS, who presented her recently with the 2021 Humanitarian of the Year Award. So without further ado, I introduce Professor Rousseau.
Thank you very much, Joshua. What a pleasure to be with all of you. Hope you can hear me well, and I'll go ahead and share screen if that's all right.
Sure, no problem. Yeah, we can hear you well. Yep, and you can see the screen as well.
Okay. And can you see my first slide?
Yep, looks perfect.
Oh, that's great. Well, Joshua, many, many thanks to you personally for the invitation on behalf of the two great organizations that are running this. I've enjoyed what I've been able to see of this very much today. I just took my mask off. I'm in clinic, so in case you wonder, it doesn't change. You know, you think you're in med school, you just have to get through that or get through residency, and you'll have weekends off, and it turns out this is a life you've chosen and not just a job. But it's a real pleasure to be with all of you today, and thank you for asking me to speak on the topic of global neurosurgery and global neurotrauma with such a distinguished group of fellow webinar panelists. So you're all quite familiar with this by now. The reason why we all in global surgery and global neurosurgery, why should we care? You've seen some of these, I won't belabor them. But what I do want to call your attention to is that picture on the upper right. You can see what happens when you have a doctor who is put in a position of authority. And this is what you all are doing in InciSioN and in NANSIG. You are creating the future leaders in medicine. And in this case, we had Dr. Jim Kim, who became president of the World Bank and was the first physician to be president of the World Bank. It was because of him being in that position that the World Bank Challenge was offered, that the Lancet picked that up, that the Lancet report on global surgery was formed, and you can see the rapid evolution of global surgery and global neurosurgery since that time. So I look forward to the future Jim Kims in InciSioN and NANSIG, who will be helping lead the way in the next decades to come. So, you know, what I'd like to talk about in my short period here is is my view of the scope of the problem of neurotrauma. And the best global studies that I've seen done on this are the accumulated studies that were accessed in 2016 by the Lancet, looking at what the global burden of trauma is. And this looks at, it gives you a bird's eye view of what the incidence of brain trauma is per 100,000 around the world. And you can see by the color charts how what the maldistribution is of in the hot areas. That's where there's a lot of brain trauma. In the cool areas there aren't. And then this is spinal cord injury, a little bit different world map, but still a great disparity in where brain and spine trauma occurs. This is by WHO region, and in all regions, motor vehicle accidents and falls are the prime culprits, but it's up to us as neurosurgeons to really delve into these details and make a difference, both in our care of the injured patients, but also in our advocacy for prevention of neurotrauma. But the disparities that I've just shown you are an example of how those types of disparities may actually lead to lack of answers to important clinical questions. I would say that if we know that roughly 90% of the brain trauma, for example, in the world is happening in places where less than 5% of the publications are coming from, there may be a fundamental disconnect between what we think the problem is and what works for that problem and what doesn't. So it's so critically important that we continue webinars like this, communication across nations and regions, so that we truly understand what we are dealing with as neurosurgeons, particularly in trauma. So there are a lot of research challenges associated with this, and we need to acknowledge the variabilities in baseline knowledge and dissemination of that knowledge in facilities and resources, financial and otherwise, and also in infrastructure. But if there is any silver lining to this pandemic, it's that our lack of physical mobility has allowed us to work on some of the infrastructure and internet and online capability. And I think going forward, God willing, this pandemic or a series of pandemics will eventually end, and our ability to hold webinars like this, to develop infrastructure of databases and coordination, even of biodepositories, will set us in good stead coming out of the pandemic. I like to speak about from pandemic to progress. And I think it's up to us to harness the difficulties of the pandemic to work better for our patients in the future. So there are some research challenges, which I mentioned, but also these great opportunities. Here's one example, and I bring this up particularly because I'm talking to young people. The paper of mine that is most cited in the pandemic, you can see the first author is Milagros Niguén Jimenez, who is a now third-year medical student from South America. She's done a remarkable job. She's first author of an important paper, and she and I have never met in person. All of our work was done with this outstanding team over the internet. So it tells you, it gives us examples of how the world is truly being flattened. Technology is allowing us to span different time zones, different locations, but it's also flattening the hierarchy. We have someone, an eminence among us, like Professor Rosenfeld, and he has the same square box on a Zoom meeting that I have, or that a first-year medical student would have. That flattening of the hierarchy is important, I think, to move toward equity and progress. One of the things that another thing we were able to do during this period was to look at neurosurgical care specifically and systematically in low-income countries. And while I think that article was important, one of the important things is what one learns in the interstices of our research. So we looked at all of those LMIC that had reported neurosurgical outcome studies in this paper, but we found that there were 15 countries that had never reported ever a neurosurgical outcome study. So now, in order to round out our global view of what global neurosurgery is, we're working on the first outcome study in many of those countries so that we can get a truly global view. Now, that involves doing some work on task shifting, which Professor Rosenfeld has spoken about, and task sharing, because in many of these countries, there isn't a neurosurgeon. We just published a paper on Somaliland, which certainly it's neurosurgery in Somaliland. There are no neurosurgeons there, but yet there is neurosurgical trauma and neurosurgical conditions exist. So we're looking at ways to bridge that gap between the medical conditions relating to neurosurgery, which are always there, whether or not the manpower is, and devising the best and safest way to be able to provide neurosurgical care to patients in those populations. The G4 Alliance, I'm proud to be on in the leadership of that group, because it brings together not only neurosurgeons, but goes beyond. Certainly, we recognize that neurosurgery does not exist and certainly can't thrive in a vacuum. We must work in concert with what are called the SOTA specialties: surgery, obstetrics, trauma, and anesthesia, because these are the specialties that require the same type of technology and resources in hospitals. We need something that's beyond the four walls that and a scrub sink that you might be able to deliver medical care. We need a little bit more than that. And so we need to work together. And that's what the G4 Alliance is all about. So even during the pandemic, we've been trying to get the word across, both by having Director General of the WHO, Dr. Tedros, appearing virtually at our annual meeting, and also preparing the general public, those who are not neurosurgeons or not even physicians, to help us do this pandemic to progress transition. So on your left, you see the webinar that was done for diplomats and bureaucrats at the UN General Assembly. We need everyone to care about global surgery, because at some point, every one of us, be they surgeon or not, is going to need surgery or have a loved one who needs surgery. In the United States, we've been working very hard to bring to the attention of our Congress the need for major funding for global surgery, which there just hasn't been before. You probably heard about the lack of funding at WHO for surgery compared with HIV, malaria, and tuberculosis, for example. And we're very encouraged that through the G4 Alliance and our advocacy group in Washington, there's a pending bill that if our budget is able to be passed for next year, there will be $100 million for global surgery going to USAID next year. We also have to recognize that we are the first line healthcare workers for patients in the tens of millions who will require rehabilitation. And we need to lock arms with our colleagues who are going to be able to help those people whose lives we save have the best possible life. So I would say the right to search for the truth, which is what we're all doing when we're doing research or sharing thoughts about global surgery, implies a duty, and we must not conceal any part of what has been recognized to be the truth. So that means that to understand global neurosurgery, we need to understand what it looks like in every country, in every city and region. We need to understand what it looks like when it's being performed by general surgeons as well as neurosurgeons. And we need to learn from where neurosurgery is being done elsewhere. And there will be many areas, I know, where the learning will be bilateral, and that ways of doing things more efficiently, more cost effectively around the world will come back to those who are currently exporting global surgery knowledge. Prevention is key, and I'm so proud of these three colleagues and friends who are the past, current, and president-elect of Think First. And Doctors Sumadani, Ullman, and Stipler are leading the way. I invite all of you to join them in the international programs of Think First, which is neurosurgery's head and spine injury prevention program. There's so many ways in which we can help patients by using our position, which is respected and occasionally revered, but always respected in every society. We need to use that bully pulpit, that podium that we have on behalf of patients for prevention. So much so that we're actually working on a project to evaluate how good is the public health education among neurosurgeons and neurosurgery residents. And we find that it could stand some improvement, particularly in this important area of head and spine injury prevention. So we put together a team from UCLA, Rutgers, and University of Michigan, along with my team, and we're looking at what are those public and global health competencies that every neurosurgery resident should graduate with. What are those platforms that should be used in order to take what we do in our daily practice and show that to society and help bring the lay public along with us to what we envision is needed in terms of trauma systems, prevention systems for our patients. So we're working actively on that, and you'll hear more about it. Those of you who aren't from the US may not recognize this fellow, but this is one of the most famous faces now in America today. And this is Dr. Anthony Fauci, who's an immunologist and allergist, but he's also been the leader in the HIV/AIDS pandemic, and now 20 years later in our COVID pandemic. He did not train as a public health official, but he has become our de facto leader in this fight against COVID. And I would urge you to think about the roles that neurosurgeons can play, who, when you look at how much of the population is affected by trauma, we need to be playing a larger role in the public in bringing prevention, treatment, funding, and research resources to bear for the things that we see every day and are often just too busy to advocate in behalf of. We also need to share our knowledge outside of our field. We love presenting in our own peer-reviewed literature. I just show this as an example of, by far, the most viewed publication that we published last year was on something that is almost a yawner for neurosurgeons. How do you take care of chronic subdural hematomas in older adults? These are the kind of things that don't raise our blood pressure very often because we just see them all the time. And yet, when we present it to a group of gerontologists who aren't the ones who deal with it, but who are very concerned about how do you recognize a subdural hematoma from dementia in an older adult who's on some type of blood thinner and who falls, that becomes an important thing for us to share. And I don't need to tell any of you young people how important sports concussions are and how really critical it is that we take them seriously and stay involved in the research and in return to play decision-making for our patients. So it's a very exciting time to be starting out one's career in neurosurgery. There's opportunities for volunteerism, for diversity, advocacy, and at the other end of the spectrum for encore careers, so that we're not going to let people retire at 60 or 70 or even 80, because there's so much that can be done with capturing webinar opportunities like this. Volunteerism, I mentioned, the emerging roles for neurosurgeons. There's Bill Gates. You also see Michael Bloomberg and General Stanley McChrystal, all of whom are best known for the careers they had after they had their careers. So I'm encouraging fellow neurosurgeons to do the same. And finally, I don't need to underscore for any of you the massive importance of looking at having our specialty reflect the patients that we serve. You just couldn't live on the planet today without being aware of movements for racial equity, first and foremost, as well as gender equity and ability equity, religious pluralism. We must recognize that it's not only the right thing to do, which is why we advocate for diversity, but it's also better. Our specialty is stronger. Our people are stronger when we're diverse. Advocacy at the level of the WHO and the WHA is something that has started and will continue, and we invite you all to join with us. We hope we'll be meeting at the World Health Assembly in Geneva this year. I have not been able to for the last 2 years. And I will share with this audience in particular the fact that everything that I know about how to work effectively in Geneva at the WHA, I learned from InciSioN. It's the honest truth. The very first time I went to Geneva for a World Health Assembly meeting, I put myself right in the middle of the InciSioN gallery and said, how do we do this? I've learned from you all, and I continue to learn from you all. Here's an example of some of the things that you can get involved in. I know part of the reason for having this webinar is to help you see what are those avenues for getting involved in global neurosurgery, if that's your interest. So these are some of the organizations within the G4 Alliance that have a neurosurgical focus. The WFNS Foundation, the Foundation for International Education in Neurosurgery. Think First, I've mentioned. Solidarity Bridge, which works in South America. The Corley Boo Foundation in Ghana. The Northwest Hospital and Medical School in Pakistan. Nigeria's Spina Bifida and Hydrocephalus Foundation, and Intersurgeon, which of course was co-founded by our dear departed and beloved British friend, William Harkness. So there's just so many opportunities to get involved. If you're not on Intersurgeon, look up Intersurgeon right now and get on your mobile phone. So I'll conclude by saying what Margaret Mead taught all of us. Never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, it's the only thing that ever has. With that, I want to leave you with my great thanks and appreciation for being with you, my contact information, and the fact that we just turned 200 years old at GW and we're celebrating that fact. So thank you so much, Joshua. Thank you, everyone in NANSIG and in InciSioN, and to all of my esteemed colleagues, both the panelists and the participants of this great webinar. Thank you.
Oh, thank you so much. Very, very kind words. We appreciate them all. So yeah, thank you so much, all of the speakers. That's been amazing. And thank you so much for bearing with us. We know we changed the date earlier this year, and you guys are all happy to confirm for the new date. Really appreciate it. And you had some amazing talks today. 6 speakers, 6 different continents. You know, I haven't been to a talk like this before, so I'm just so glad to have such an esteemed panel with us today. Just before we wrap up and finish up, we do have a few more questions that came in. If that's okay for anyone that's still available to answer questions that's still on the panel. So yeah, this one goes out to anybody, but how can junior doctors or budding surgeons get started in their journey in global health or neurosurgery? Anyone can answer, feel free to.
The question is how to get involved?
Yeah, so how can junior doctors or budding surgeons get started in their journey in global health or neurosurgery?
Well, I'll take a stab, but I think I see Professor Rubiano and Professor Rosenfeld are on here as well. And I tried to give a sense of that in my talk, but the first thing is I usually start local and then regional and get bigger. So there's probably someone at your school or university who's involved and probably a faculty member. I'd start there. Then there's a national organization, and NANSIG is certainly part of the British Neurosurgical Society. So you go there, and then there's the European Association, which has EANS, which has a young members forum. The WFNS has that as well. So that's sort of the rippling way of being involved. But also, we've all given you our contact information. You can write directly to us and say, I've got a project, how do I get started? Or can you direct me to someone to get involved? So there's the gradual progressive way of doing it organizationally, and then there's the direct way.
That's a great answer. Thank you. So another question is, how can one pursue a career in neurosurgery and also like a career in public health, and what's the link between the two? So what kind of inspired you guys to get involved in both neurosurgery and like public health?
Well, let me take a little bit of that. And definitely, I think based on what Dr. Rousseau just mentioned is that it's very important, like to feel the call, it's like you feel that you need to do something bigger than yourself, and you need to move action for things that sometimes affects not only yourself, but affects all the people around, even in other regions of the world. So definitely, I think the most important issue is that you feel how to move ahead within this area. And as neurosurgeon, it's very important to be aware of you need to understand the public health environment, the public health issues, because if you focus only in the procedures itself that you do surgically, you have a tunnel vision that didn't allow you to sometimes understand what is happening around. So if you want to build a career in global neurosurgery, it's because you really want to do something for other people. And definitely this allowed you to move for understanding what is happening. This is not always easy, because when you are during your training, you are very focused on developing the surgical skills. So you are very dedicated. You feel that everything is surrounded, just focus on that topic. But sometimes you need to dedicate more of your time in order to move ahead with all these public health issues. So it's just, like I mentioned, it's a call that you feel, and it's a call that you will move with your heart.
Wow, thank you very much. Very passionate answer. Thank you. Another question that's just come in is coming from the chair of NANSIG. And they wanted to know, how can people leading organizations such as NANSIG and InciSioN, we have both chairs for both societies here today, how can they ensure that we continue to make progress on the front of global neurosurgery, not just in inclusivity, but also in terms of making sure that people from LMICs can lead these processes and support them as much as possible?
Well, I'll jump in there because this is a topic that's really near and dear to my heart. One of the most important aspects, I think, of global surgery going forward is the anti-racism aspect of it. If we look at global surgical disparities, global health disparities, many, I would say most, in fact, nearly all, are related to prior colonial powers and a disparity in the way people were treated because of our shared history around the world. And so I personally think that a strong anti-racism sentiment is going to be essential to progress in global neurosurgery, in global surgery, and in global health. And one of many elements of a proactive anti-racism approach is exactly what your questioner has asked, and that is having the full participation and voices of those people who are from low and middle income countries that are low and middle income countries because of a colonial heritage in many cases, have them be authors on papers, leaders in organizations, and so forth. That's my personal opinion.
It's a great answer. Thank you. So another question here. What are options for resident neurosurgeons from developing countries such as Pakistan to get optimum and latest neurosurgical training in developing countries and serve their people?
Well, I think as Jeff already said, it's we, as the World Federation of Neurosurgical Society, has decided quite a few years ago to support training of neurosurgeons in Africa, not in other countries. Why? Because we need the African neurosurgeons or Asian neurosurgeons to be trained where they are. Then, as Jeff said, it may be important to have a fellowship on a specific target. For instance, we have specific target fellowship for countries, low and middle income countries. Specific target, I mean, as Andres Rubiano has seen, neurotrauma or endoscopic surgery or tumors, low-grade tumors, anything but with a specific interest after graduation and after you are a neurosurgeon, after you are specialized in neurosurgery, then you may have a short period outside for a specific target, and then you come back. I think this is the best way to do it. The way to come to European or Western countries usually was ended by staying there, not coming back. And this is why the World Federation now support fellowship in Africa and Asia and not in Europe. So it is a different approach. But I think the real one is graduation and training in your country or nearby, and then a fellowship outside.
Great answer. Thank you. So I had another question come in, and they wanted to know what scope is there for Western medical students, such as UK students, to conduct an audit and improve service in third world countries?
I can give some answer to that is related to our experience within our program. As our program is actually based for neurosurgeons, as Professor Servadei mentioned, that want to enhance their training in neurotrauma specifically, we have been working additionally with foreign medical students that want to gain experience in low resources settings. So definitely the idea is that if you engage as medical student, working specifically with medical students from all these countries, you create an important network of development for learning yourself from first hand in the region, how you can contribute from your perspective to the development of many of the activities that are needed. So definitely the interaction of students at different levels within these programs also that are sometimes focused for advanced provider, but definitely they learn into the process interacting with all of them, how they can create their own pathway for the future. And what we have doing here is that we have all these people together. You know, we have medical students, not only from local universities, but also from foreign universities working together in different topics. They do research together, they go to clinical practice together, and also they interact with other specialties that are involved in the care of the acute patients, you know, like nurses, rehabilitation patients. So this creates a really interesting network of evolving together in order to improve conditions all around.
Just to add to that, I think that medical students from advanced countries often have advanced skills in IT and computers. And if they visit a developing country into a neurosurgery department there, who is not doing much research in that, there isn't much research going on in the department because they're so busy with their clinical load. And also the people in the department may not have had training in data collection and data management. And so if students can come in and actually assist the department to develop their IT infrastructure and skills and start collecting data, because data is power, really. Once you have the data, you can start to argue your case. Without the data, the politicians don't listen. They don't want to know you. But if you have the data to back up what you're saying about the prevalence of particular problems and what the outcomes are with surgery, without surgery, then you can start to win some arguments. So it's crucial that departments in the developing countries have data collection which is reliable and continuous, and so this is where I think medical students can help a lot, because they can visit, they can help set up the data sets and help the local staff to know how to use these systems so that it can go on after the student has left. And because of internet connections, the student can still be involved in the research even after they've left that visit that they've just, where they've set all this up. So it's just a suggestion, but I see that as an important role for medical students, because they often have such advanced knowledge and skills in IT and data management.
Thank you. Good answer as well. Thank you. Another question has come in. Someone is asking, what would you suggest to medical students in order to gain more neurosurgical experience and teaching when they don't have a neurosurgeon or neurosurgery department in the medical school or city of study?
Well, this is happening, unfortunately, even in Western countries. So we have a program in Europe called Erasmus, where we exchange students between European university. And very often, Erasmus students come for seeing neurosurgeries from another country because they are in a university without neurosurgery. So that's not uncommon. I think, and in the African paper from our colleagues from Africa, they were also citing that many universities in Africa do not have a neurosurgical program. What is our suggestion, and what do we do in many places in Europe? We complete the surgical training for students with some lectures coming from another university. So we do have exchanges of students, or we do have teachers coming from other university. I think, in my opinion, neurosurgery is an important part of neuroscience. Maybe for us the most important, but anyway, it's surely an important part of neuroscience. So the teaching for students and the possibility to see patients is extremely important for us as neurosurgeons. So I think the way to do it is a sort of connection between university with and without neurosurgery.
Thank you very much for that. Another question that's just come in is someone is wondering how, if they were to pursue an academic training program, would this compromise the amount of time they would have to spend on developing surgical skills, as they understood it to mean that they would spend more time in surgery and they would have less time for hands-on surgical training? Do you believe that pursuing this academic program would affect their ability to gain the same amount of surgical training as their colleagues?
I'd like to take that one because this is something that it comes up a lot, and I think it's really important. You know, as a medical student or even early in residency, people see wonderful talks by some of my colleagues on these panels, or they about global neurosurgery. They see global neurosurgery and lions and tigers and polar bears on the pictures and so forth, and it looks great, but it is very important to recognize that unless first and foremost you are a solid, good neurosurgeon, your ability to contribute as a global neurosurgeon will really not be what it should be. You have to focus on first things first, and that means becoming a good neurosurgeon. Doesn't mean you have to wait till the end of your training before you get involved in these things, but if you think about what your daily priorities are, they have to be taking the best possible care of the patient in front of you, and then you have to build time around that for your global interests and your global research. It's all doable, but it is important to keep a focus on the fact that you're a doctor, you're a surgeon, you're training to become one, and your utility to the rest of humanity starts with your ability to care for them neurosurgically.
Thank you. Another question that's come in. Someone is wondering, how do you, like, very early stage, such as first year medical students, essentially just students without much experience, how can they get more involved in global neurosurgery publications and research, similar to the examples that Dr. Rousseau showed in her talk?
Well, I have seen, as you have seen in my presentation, and Gail and Andres know very well, and Jeffrey also, medical students are a very important part of our publication and of our work. I mean, as I told you, I was, let's say, amused that out of about 30 most publishing authors in the world about global neurosurgery, 4 are students. So we have in mind the publication of our group and the group of Cambridge. Almost any publication, we have at least 2-3 students. The students are an important part of this work we are doing in global neurosurgery. I think we all agree. Then I use the podium to respond. There is a question, Erasmus is possible for, Erasmus exchanges are possible for medical students. Erasmus is a program, is an European program for exchange of medical student who is now, let's say, open to students coming from outside Europe. So, but basically is an European exchange program for students with a specific target, let's say neuroscience, gynecology and obstetrics, and so on. So it's an exchange of students, which was born in Europe, and now it's a worldwide program.
Oh, thank you. That was actually the next question. Someone wanted to know about Erasmus and how it works for medical students. So you can cover 2 in 1 in there. Thank you. Another question that's come in, someone is wondering, would experience in modern/well-equipped hospitals in high-income countries be valuable or even essential before going out to serve in impoverished areas? For example, for a student who is interested in medical missions, or would it be encouraged to still be serving where the needs seem to be early on?
I'll take that. The whole notion of going on medical missions is something that we're getting away from. We're focusing more on the idea of service through education. And we hope that education will always be bilateral and that the teachers and learners change places all the time. I'll give you a good example. I work in Washington, D.C., and we're just breaking ground on a new hospital in an impoverished part of Washington, D.C. And I'm anticipating that much of what we've been doing with our community health workers in Uganda in looking at things like diabetes and hypertension and going house to house, hydrocephalus, and teaching people how to measure head circumference size and so forth. Those are things that are being done effectively and cost effectively in other places. And that kind of teaching is going to come back to us. So I think there's many ways at every level of the socioeconomic scale to be able to change things. And I do think we should get away from the notion of global surgery being mission-based or even requiring travel. There's global neurosurgery education going on right now, and most of us are in our homes and home countries.
Thank you so much, everybody. Really appreciate all the answers, all the questions from the participants and all the talks from the speakers. I've had an amazing time, and from a lot of the feedback that I've got from the chat, I'm sure a lot of people have as well. So essentially, yes, that would conclude our conference. There's a few more things that I'll plug in for some upcoming agenda for both NANSIG and InciSioN. But in terms of the actual Global Neurosurgery Conference, that is the end. So thank you so much for everyone for coming. Thank you for all the questions and all the answers and all the talks and the speakers. We really appreciate it.
Thank you, Joshua,
Bye.
for organizing this wonderful meeting. Goodbye.
No
Thanks,
problem at all.
everybody.
Bye.
Joshua,
See
back to
you.
work. Bye-bye.
Bye.
Wonderful.
No problem at all. Thank you. So yes, I hope you guys enjoyed the conference we had today. If conferences are your thing, we do have a NANSIG conference coming up in the next few weeks. Well, 2 weeks from now, actually. And it's going to be 3 weeks from now. And it's going to be our 11th annual Neurosurgery Careers Day. I believe there's a very limited amount of tickets left, like single digits. So if there's something you're interested in, please try and get your tickets as soon as possible. They are on sale now, and more information can be found on our social media sites as well. It should be a great event. We do plan to have it in person, so it'll be in Liverpool this year. Unfortunately, we couldn't have it in person last year, so we're really looking forward to having it this year. But yeah, if you're interested in finding more about NANSIG and getting involved with the annual's Careers Day, this is a great opportunity for you. So please feel free to check this out. And regarding InciSioN, they will have the upcoming journal club will be happening soon. This will be on January 26th, and it'll be on cardiothoracic surgery. And we'll be looking at a paper which discussed the challenges and possibilities of developing cardiac surgery in a peripheral hospital of low and middle income countries. So this is actually a retrospective study review examining almost 3,000 patients across 4 years regarding cases that were diagnosed and consulted in a new peripheral hospital in Nepal. So if you're interested in global cardiothoracic surgery, this would be a great event for you to check out. More details, such as the sign-up link, will be provided on the InciSioN social media sites. So please feel free to check that out as well. For NANSIG's next webinar, we are delighted to have Professor Karen Moresco. She's a professor and chair of the Department of Neurosurgery at the University of Michigan, and the first woman to actually head a neurosurgical department at any medical school in the US. This was first official in 2005. Even though she was born with spina bifida, she did not allow her health condition to stop her from achieving her goals. And we are delighted to have her present a talk for us at NANSIG next month on Zoom. More details are also to follow and can be found on our social media sites when they go up soon. For incision as well, we do need some more reps. So the following universities currently do not have ambassadors. So we'll be sending out application forms for people to apply for those. Anyone here who's a member of any of these universities and would like to apply to be a rep, you will have more information about that coming soon. So keep checking our social media sites, and hopefully a link will go up soon for people to sign up so you can fill out those remaining university spots. In the spirit of more recruitment, NANSIG's committee's tenure, the last tenure anyway, is coming to an end. So we're looking for some new members to join our national committee. So if you're a UK medical student or junior doctor and you have an interest in neurology or neurosurgery, we do have committee recruitment coming up soon. So applications are now available, I believe, and the Google form is out. The deadline is Monday the 17th, 12 p.m. So everyone who's interested in joining the committee, please feel free to apply. There's a lot more information on our social media sites and the websites as well. So please check them out as well. And we also have an essay competition that's going out now. The deadline for that is Saturday, 30th of April, so you still have some time. There are 2 essay options, which are displayed here, and more information again can just be found on our website as well. I thank everyone for attending. I wanted to put down our social media details here, just in case anyone wanted to check out any of the things I mentioned before, or if you wanted to get more involved with NANSIG and InciSioN, that's also an option as well. We really appreciate your attendance here. This is the first time we've ever hosted an event like this before in between the 2 societies, and I feel like it went really well today. So we couldn't have done it without you, and we appreciate all the effort and the time you guys have given up for us today. But yeah, that concludes our conference today. Thank you so much for coming, and hope to see you next time. And yes, for those who are wondering for certificates of attendance, when you signed up on the form, there was also the option to, if you want to complete the rest of the survey, there was an option if you want to do that, and you can get a certificate of attendance. We do have a list of all the emails of the people who have applied for that. So we'll be sending you out the links for the certificate very soon. So thank you so much for that. And yes, before I forget, that conference, the Neurosurgical Careers Day conference, the virtual attendance is also free for anyone who's outside of the US, the UK. So feel free to check that out in case you feel like you can't make it in person. Thank you very much, and hope everyone has a great Saturday.